Hi, this is Amber Knowlton. This is Unit 3. We're starting nursing assessment of the cardiovascular system in Chapter 32. Factors that affect cardiac output, your preload of the heart, so the volume of blood in the ventricles at the end of diastole, contractility, and afterload. Afterload is the peripheral resistance against which the left ventricle must pump. So a patient is receiving a drug that decreases afterload. To evaluate the patient's response to this drug, what is most important for the nurse to assess? And the answer would be C, blood pressure. The vascular system, arteries carry oxygenated blood away from the heart, except for the pulmonary artery. Veins carry deoxygenated blood toward the heart, except for the pulmonary veins. Small branches of arteries and veins are arterioles and venules. Blood circulates from the heart into arteries, arterioles, capillaries, venules, and veins, and then back to the heart. The arterial system differs from the venous system by the amount and type of tissue that makes up arterial walls. Arteries and arterioles, the large arteries have thick walls that are composed mainly of elastic tissue. This elastic property cushions the impact of the pressure created by ventricular contraction and provides recoil that propels blood forward in the circulation. Large arteries also contain some smooth muscle. Examples of large arteries are the aorta and the pulmonary artery. The innermost lining of the arteries is the endothelium. The endothelium serves to maintain homeostasis, promote blood flow, and under normal conditions, inhibit blood coagulation. When the endothelial surface is disrupted, the coagulation cascade is initiated and results in the formation of a fibrin clot. Capillaries, the thin capillary wall is made up of endothelial cells with no elastic or muscle tissue. The exchange of cellular nutrients and metabolic end products take place through these thin-walled vessels. Capillaries connect arteries and veins. Veins and venules. Veins are large diameter, thin-walled vessels that return blood to the right atrium. The venous system is a low-pressure, high-volume system. The larger veins contain semilunar valves at intervals to maintain the blood flowing forward toward the heart and to prevent blood from flowing backward. The amount of blood in the venous system is affected by a number of factors, including arterial flow, compression of veins by skeletal muscles, alterations in thoracic and abdominal pressures, and right atrial pressure. The largest veins are in the superior vena cava, which return blood to the heart from the head, neck, and arms, and the inferior vena cava, which returns blood to the heart from the lower part of the body. Blood pressure, the arterial blood pressure is a measure of the pressure exerted by blood against the walls of the arterial system. The systolic blood pressure is the peak pressure exerted against the arteries when the heart contracts. The diastolic blood pressure is the residual pressure in the arterial system during ventricular relaxation or ventricular filling. Blood pressure is usually expressed as the ratio of systolic to diastolic. The two main factors influencing blood pressure are cardiac output and systemic vascular resistance. Blood pressure equals the cardiac output times the systemic vascular resistance. Systemic vascular resistance is the force opposing the movement of blood. This force is created primarily in small arteries and arterioles. Normal blood pressure is systolic blood pressure less than 120 and diastolic greater than 80. Measurement of blood pressure. Blood pressure can be measured by invasive and non-invasive techniques. The invasive techniques consist of catheter insertion into an artery. The catheter is attached to a transducer and the pressure is measured directly. Non-invasive, indirect measurement of blood pressure can be done with a sphygmomanometer and a stethoscope. The sphygmomanometer consists of an inflatable cuff and a pressure gauge. The blood pressure is measured by auscultating for sounds of turbulent blood flow through a compressed artery. These are termed Korotikoff sounds. The brachial artery is the recommended site for taking a blood pressure. After placing the appropriate size cuff on the upper arm, inflate the cuff to a pressure 20 to 30 above the systolic blood pressure. This causes blood flow in the artery to cease. If the systolic blood pressure is not known, estimate the pressure by palpating the brachial pulse and inflating the cuff until the pulse ceases. The pressure noted at this time is the estimated systolic blood pressure. Inflate the blood pressure cuff 20 to 30 above this number. As the pressure in the cuff is lowered, the artery is auscultated for Korotikoff sounds. There are 5 phases of these sounds. The first phase is a tapping sound caused by the spurt of blood into the constricted artery as the pressure in the cuff is gradually deflated. This is the systolic blood pressure. The 5th phase occurs when the sound disappears and is noted as the diastolic blood pressure. Proper blood pressure techniques, correct cuff size, positioning of the arm at the heart level are all essential for accurate readings. Another non-invasive way to measure blood pressure indirectly is an automated device that uses oscillometric measurements to assess blood pressure. Though this method does not involve auscultation, the same attention to proper technique is essential for accuracy. Finally, systolic blood pressure and pulse can be assessed using a Doppler. The handheld transducer is positioned over the artery. You identified by an audible pulsatile sound. The cuff is applied above the artery, inflated until the sound disappears, and then another 20 to 30 beyond that point. The cuff is then slowly deflated until sounds return. This point is the systolic blood pressure. Automated blood pressure devices are another non-invasive way to measure blood pressure indirectly. This method does not involve auscultation. The same attention to proper technique is essential for accuracy. This picture here is showing the measurement of blood pressure using the Doppler. The handheld transducer is positioned over the artery. The cuff is applied above the artery. It's inflated until the sounds disappear, and then another 20 to 30 beyond that point. The cuff is then slowly deflated until sounds return. This point is the systolic blood pressure. And again, in the picture, you see how they're pushing the transducer down on the arm. You don't want to push the transducer down too far or else you're going to compress the artery. Pulse pressure is the difference between the systolic and diastolic blood pressure. It is normally about 1/3 of the systolic blood pressure. If the blood pressure is 120/80, the pulse pressure is 40. An increased pulse pressure may occur during exercise or in individuals with atherosclerosis of the large arteries as a result of increased systolic blood pressure. Decreased pulse pressure may be found in heart failure or hypovolemia. Mean arterial pressure, or MAP, refers to the average pressure within the arterial system that is felt by organs in the body. It is not the average of the diastolic and systolic pressures because the length of diastole exceeds that of systole at normal heart rates. MAP is calculated as systolic blood pressure plus 2 diastolic blood pressures together. Take that number and divide it by 3. You do need to know how to calculate the mean arterial pressure. So you want to take your diastolic blood pressure and multiply it by 2. Take that number and add it to the systolic blood pressure. Then take that number and divide it by 3. You do need to know how to calculate the MAP. A person with a blood pressure of 120/60 has a MAP of 80. A MAP greater than 60 is needed to adequately perfuse and sustain vital organs of an average person. When the MAP falls below this number for a period of time, vital organs are underperfused and will become ischemic. Gerontologic considerations. One of the greatest risk factors for cardiovascular disease is age. Cardiovascular disease remains the leading cause of death in older adults. in adults older than 85. It is the most common cause of hospitalization and the second leading cause of death in adults younger than 85. The most common cardiovascular problem is coronary artery disease, secondary to atherosclerosis. It is difficult to separate normal aging changes from the pathophysiologic changes of atherosclerosis. Many of the physiologic changes in the cardiovascular system of older adults are a result of the combined effects of the aging process, disease, environmental factors, and lifetime health behaviors rather than just age alone. With increased age, the amount of collagen in the heart increases, and elastin decreases. These changes affect the myocardium's ability to stretch and contract. One of the major changes in the cardiovascular system is the response to physical or emotional stress. In times of increased stress, there is a decrease in cardiac output due to reduced contractility of the heart rate. The resting supine heart rate is not markedly affected by aging. When the patient changes positions, for example, sits upright, the sympathetic nerve pathway must be impacted by fibrous tissue and fatty deposits, resulting in a blunted heart rate response. Cardiac valves become thicker and stiffer from lipid accumulation, degeneration of collagen and fibrosis. The aortic and mitral valves are most frequently affected. These changes result in either regurgitation of blood when the valve should be closed or narrowing of the orifice of the valve, stenosis, when the valve should be open. The turbulent blood flow across the affected valve results in a heart murmur. The number of pacemaker cells in the sinoatrial node decreases with age. By age 75, a person may have only 10% of the normal number of pacemaker cells. This is compatible with adequate SA node function, although it may account for the frequency of some sinus dysrhythmias in older adults. Similar decreases also occur in the number of conduction cells in the internodal tracts, the bundle of His, and the bundle branches. These changes contribute to the development of atrial dysrhythmias and heart blocks. About 50% of older adults will have an abnormal resting EKG. The autonomic nervous system control of the cardiovascular system changes with aging. The number and function of beta adrenergic receptors in the heart decrease with age, so the older adult not only has a decreased response to physical and emotional stress, but also is less sensitive to beta adrenergic agonist drugs. The lower maximum heart rate during exercise results in only a twofold increase in cardiac output, compared with the 3 to 4 times increase seen in younger adults. Arterial and venous blood vessels thicken and become less elastic with age. Arteries increase their sensitivity to vasopressin, which is an antidiuretic hormone. Both of these changes contribute to a progressive increase in systolic blood pressure and a decrease or no change in diastolic blood pressure with age. Thus, an increase in the pulse pressure is found. Hypertension is not a normal consequence of aging and should be treated. Valves in the large veins and the lower extremities have a reduced ability to return the blood to the heart and may result in the development of dependent edema. Orthostatic hypotension is estimated to be present in more than 30% of patients over age 70 with systolic hypertension and may be related to medication and or decreased baroreceptor function. Postprandial hypotension, decrease in blood pressure of at least 20 that occurs within 75 minutes after eating, may also occur in about a third of otherwise healthy older adults. Both may be a source of falls in the older adult. Despite the changes associated with aging, the heart is able to function adequately under most circumstances. In your book on page 691, table 32.1, gerontologic assessment differences are outlined. Assessment of the cardiovascular system. A careful health history and physical exam will aid you to distinguish symptoms that reflect a cardiovascular problem from problems of other body systems. Explore and document all clues that alert you to the possibility of underlying cardiovascular problems. History of present illness. Ask the patient what problem has brought him or her to the healthcare facility. Past health history. Many illnesses affect the cardiac system directly or indirectly. Ask about a history of chest pain, shortness of breath, fatigue, alcohol, tobacco use, anemia, rheumatic fever, strep, throat infections, congenital heart disease, stroke, palpitations, dizziness with position change, syncope, hypertension, thrombophlebitis, intermittent claudication, varicosities, edema. Medications, assess the patient's current and past use of meds, any over-the-counters, herbal supplements, prescription drugs. List all the patient's medications, dosage time, last dose, patient's understanding of the drug and purpose and side effects. Many non-cardiac drugs can adversely affect the cardiovascular system and should be assessed. Surgery or other treatments, ask the patient about specific treatments, surgeries, hospital admissions related to cardiac problems, explore any admissions or outpatient procedures, diagnostic workups, any EKG, chest x-ray. Functional health patterns, health perception, health management pattern. Does the patient practice any preventative measures to decrease their risk for heart disease? Have they noticed an increase in cardiac symptoms? Does their heart problems cause them to be unable to care for themselves? Do they foresee any potential problems with caring for themselves? Have they ever used tobacco? If so, what form, how much, how long? Have they ever tried to quit? How much, how often, and how much alcohol do you drink? Nutrition, describe your daily diet, salt, fat, liquid intake. What is your present weight? What was your weight a year ago? Does eating cause fatigue or shortness of breath? Elimination pattern. Is there any feet or ankle swelling? If yes, how far up the legs does it go? Away after sleeping all night? Ever taken any meds to help get rid of excess fluid or relieve constipation? Any problems with urination? Ever have to strain to have a bowel movement? Activity, exercise pattern. Are daily activities or exercise limited from heart problems? When were you last able to comfortably perform your usual activities? Do you experience any discomfort or side effects from your exercise? Can you comfortably walk and talk at the same time? How often do you attend activities outside your home? What was your most strenuous activity in the last few weeks? Sleep and rest pattern. How many pillows do you use at night? Do you wake up suddenly and feel like you can't catch your breath? History of sleep apnea. How many times do you wake at night to use the restroom, to urinate? Cognitive perceptual. Do you ever experience dizziness, fainting? Do you ever find it difficult to verbally express yourself or remember things? Do you experience any pain as a result of your heart problems? Self-perception. Have your perceptions of yourself changed since you were diagnosed with a heart problem? How has your heart disease affected the quality of your life? Role relationship. Has this illness affected any of the roles that you play? How have your significant others been affected? Sexuality, reproductive. Has your heart problems caused a change in sexual activity? Do you experience any heart-related symptoms during sexual activity? Do any of your medications affect your ability to participate in sexual activities? Females, are you currently taking oral contraceptives, hormone therapy, drug therapy for breast cancer? Coping and stress. Describe your normal coping mechanisms. To whom or where would you turn for during a time of stress? Do you practice any stress reduction techniques? Do you have a history of depression? Do you feel capable of handling your situation? Do you experience any heart symptoms, chest pain, palpitations during stress or anger? And values and belief. What influence have your values or beliefs had during your illness? Do you feel any conflicts between your values or beliefs in the plan of care? Describe any cultural or religious beliefs that may influence your management of your heart problem. Objective data, vital signs. After you observe the patient's general appearance, obtain vital signs, measure the blood pressure bilaterally. These readings normally vary from 5 to 15. Use the arm with the highest blood pressure for subsequent blood pressure measurements. Take orthostatic postural blood pressures and heart rates while the patient is supine, sitting with legs dangling, and standing. Systolic blood pressure should not decrease more than 20 from the supine to the standing position. Heart rate should also not increase more than 20 from supine to standing. Inspection, inspect the skin for color, hair distribution, venous pattern. Inspect the extremities for conditions such as edema, dependent rubor, clubbing of the nail beds, varicosities, lesions, such as stasis, ulcers. Inspect the large veins in the neck, internal and external jugular, while the patient is gradually elevated from a supine position to an upright position. Distension and prominent pulsations of these neck veins, referred to as jugular venous distension, can be caused by right-sided heart failure. Palpate the upper and lower extremities for temperature, moisture, pulses, and edema bilaterally to assess for symmetry. Look for edema by depressing the skin over the tibia or medial malleolus for 5 seconds. Normally, there is no depression after releasing pressure. If pitting edema is present, grade it from 1+ to 4+. Capillary refill is used to assess arterial flow to the extremities. Position the patient's hands near the level of the heart and squeeze the nail bed to produce blanching. Observe for the return of color. This should occur in less than 2 seconds with normal peripheral perfusion and cardiac output. Palpation also involves assessment of arterial blood flow. Auscultation, an artery that is narrowed or has a bulging wall may create turbulent blood flow. The abnormal flow can create a buzzing or humming termed a bruit. This is heard with a stethoscope placed over the vessel. Auscultation of major arteries such as the carotid arteries, abdominal aorta, and femoral arteries should be part of the initial cardiovascular assessment. This picture here is showing the common sites for palpating arteries. This picture is in your book on page 695, figure 32-6. Palpate the pulses in the neck and extremities for information on arterial blood flow. Assess the rhythm. Are they regular, irregular, the force? It is important to palpate each carotid pulse separately to avoid vagal stimulation and possible dysrhythmias. Compare the characteristics of the arteries on the right and left extremities simultaneously to determine symmetry. When palpating the arteries identified in this figure, rate the force of the pulse when it is felt. This is done by using a scale of 0 being absent, 1 plus weak, 2 plus normal, 3 plus increased full bounding. The rigidity or hardness of the vessel should also be noted. The normal pulse will feel like a tap, whereas a vessel wall that is narrowed or bulging will vibrate. And the term for the palpable vibration is thrill. So you hear a bruit, you feel a thrill. Diagnostic studies of the cardiovascular system. Serum lipids consist of triglycerides, cholesterol, phospholipids. Triglycerides are the main storage form of lipids and make up about 95% of fatty tissue. Cholesterol, a structural component of cell membranes and plasma lipoproteins, is a precursor of corticosteroids, sex hormones, and bile salts. In addition to being absorbed from food in the GI tract, cholesterol can also be synthesized in the liver. Okay, I paused it.
You didn't pause the recording. Click here.
Phospholipids contain glycerol, fatty acids, phosphates, and a nitrogenous compound. Although formed in most cells, phospholipids usually enter the circulation as lipoproteins that are synthesized by the liver. Serum lipids circulate in the blood bound to protein. These are often referred to as lipoproteins. Apoproteins are water-soluble proteins that combine with most lipids to form lipoproteins. Different classes of lipoproteins contain varying amounts of the naturally occurring lipids. These would be, for example, your low-density lipoproteins. The LDLs, these are mostly cholesterol with moderate amounts of phospholipid. The HDLs, the high-density lipoproteins, about 1/2 protein and 1/2 phospholipids in cholesterol. And the VLDLs, the very low-density lipoproteins, these are primarily endogenous triglycerides with moderate amount of phospholipids and cholesterol. A lipid panel usually measures cholesterol, triglycerides, LDLs, and HDLs. Elevations in triglycerides and LDL are strongly associated with coronary artery disease. An increased HDL level is associated with a decreased risk of coronary artery disease. High levels of HDL serve as a protective role by mobilizing cholesterol from tissues. Although the association between elevated serum cholesterol levels and coronary artery disease exists, a measure of total cholesterol alone is not sufficient for an assessment of coronary artery disease. A risk assessment is calculated by comparing the total cholesterol to HDL ratio over time, and an increase in the ratio indicates increased risk. This provides more information rather than just looking at one value alone. The patient must fast before a lipid panel, before the blood is drawn for a lipid panel to remove the effects of a recent meal. And this is it for the chapter 32 cardiovascular assessment.